Hey there, this is Krisha again, and welcome to my second video in my series of how to understand and analyze a research paper. You can also check out my first video, and if you like the series, give this video a thumbs up and subscribe to my channel. Let's get started. So the article today we're going to be looking at is actually a review. It's about Parkinson's disease, the clinical features and diagnoses. And this article is a little bit easier than the previous one. So if you're going through the videos, this is probably the first one you want to do, just because it's a little more basic, a little bit easier to understand. And I think people might have an easier time just getting through this as well, because as we see the length here, it's like 9 pages, including acknowledgements and the references, which is a big improvement from the 23-page one. Okay, so diving into it then. Looking at the title, you may or may not know what Parkinson's disease is, and either way that's fine, because they go ahead and explain everything in the first few paragraphs. So you don't necessarily need to come in with any prior knowledge here, but just kind of keep it, any terms that you don't know, maybe write it down or keep it in mind so you can go back to them and you can go and define them afterwards. I usually just keep a notebook by me when I'm doing this so I can just jot down anything. So let's look at the abstract next. Take a minute to read over that, and we'll go over it together after. Okay, so they have 4 categories in the abstract itself: the objective, methods, results, and conclusions. So if you look at the objective, first of all, they do actually go ahead and define PD right away. They say it's a progressive neurological disorder characterized by a large number of motor and non-motor features that can impact function to a variable degree. And then they also define here and establish what the article itself is going to be talking about. It talks about the clinical characteristics of PD, with emphasis on the features that differentiate it from other Parkinsonian disorders. So we're basically looking at what makes PD what it is, and what makes it different from other things that might have similar symptoms but aren't quite the same. Next, going down this list, they talk about the methods, and they perform this study through a Medline search. And then they give you more specifics about the search terms. The next category is the results, and they say that because there is no definitive test for diagnosis, the disease must be diagnosed based on clinical criteria, and then they talk about what some of this clinical criteria might be. They name rest tremors, bradykinesia, rigidity, and loss of postural reflexes, which are kind of the main signs of PD, but as they show here, all of this stuff actually keeps going. Pretty much all of this, yeah. Oh wait, sorry. Up until there are also other possible features of PD, but they don't show up in everyone. And then they mention from that point on, the part I accidentally highlighted before, here, they say that if any of the initial criteria that they named, like absence, like rest tremor, gait difficulty, postural instability, if any of these things aren't there, then it's probably not PD. So right here they've established what the differences are between PD and other diseases that might be similar to it. So the conclusion from this is that a thorough understanding of the broad spectrum of clinical manifestations is essential for proper diagnosis, and that genetic mutations or variants, neuroimaging abnormalities, and other tests are potential biomarkers that may improve diagnosis and allow the identification of persons at risk. Okay, so they're basically saying that you need to understand all of these possible clinical manifestations of PD to really be able to diagnose it. And that, like other neuroimaging techniques and other ways of definitively like knowing that there is PD based on criteria other than like just symptoms isn't really there yet, but if it does come along, it can improve diagnosis. So that is really what we get from the abstract here. It's pretty straightforward in this one. And then it goes right from there into the first body paragraph. We have a short intro actually. And it starts off by introducing James Parkinson in 1817. At this point, he wrote an essay on the shaking palsy. Funny story, he actually didn't know that this was a disease back then. Nobody did really. He was just kind of walking the street and noticed some people had tremors. And he kept observing them, just literally observed people on the street. And that's how PD was discovered. And now, like 200 years later, it's finally been recognized as an own separate disease, and it has very definite clinical features that differentiate it, and some medicines that can help to suppress symptoms and that can help to manage the disease. But unfortunately, there still isn't a cure. So let's see what this disease is. In 1919, after the original description by Parkinson, it was recognized that patients with PD lose cells in the substantia nigra, and after 140 years, dopamine was discovered as a putative neurotransmitter. Then up here they go on to say that dopamine concentrations are markedly decreased in the striatum of patients with PD. And as you can see in these two sections, Parkinson's disease is also characterized by a loss of dopaminergic cells that produce dopamine, in the substantia nigra, in the basal ganglia, in the striatum, basically in many different regions of the midbrain. So, okay, now we have somewhat of a definition of what this disease is, what some clinical manifestations of it are. So, what's the treatment? Well, as I mentioned before, there are some ways to manage it, but there's no definitive cure. One of the most popular treatments is levodopa, as they mention here. It was first injected to improve akinesia in patients, or bradykinesia, it's like the same thing really, and was followed by oral levodopa later. Usually nowadays it's used in conjunction with carbidopa. It's like a combination medication. And that's like the main kind of treatment for it really. What else do they see here? More recently, genetic mutations, abnormal handling of misfolded proteins, increased oxidative stress, mitochondrial dysfunction, inflammation, and other pathogenic mechanisms have been identified as contributing factors in the death of dopaminergic and non-dopaminergic cells in the brains of patients with PD. Yeah, so this is very similar to what we were talking about before, with the death of dopaminergic cells in PD patients. However, there are also all these other possible contributing factors that they just listed here, which also might play a role in the disease. And yeah, maybe we'll see how they actually affect PD patients later on in this article. We have yet to see that though. Oh wait, never mind. They do say here, it is beyond the scope of this review to discuss the various pathogenic mechanisms, management or treatment-related complications that have been subject of recent reviews and volumes. So there are other studies though that do talk about this stuff. So if you want to, they do seem to have some sources here, 10 and 11. If you go down to the references, you can actually go into those articles and get additional info because it'll take you to other articles that this particular research paper got information from. So that's a really cool thing about these. You can just kind of keep going down this rabbit hole from one paper to the next through the reference section. But yeah, so far through the abstract and the first paragraph here, we have a pretty good picture of what Parkinson's is. And the next section here is clinical features, so let's take a look at that. So starting off with the clinical features section here, I'm just gonna scroll through it real quick, and it seems like what they're talking about in this section is like different ways to quantify and measure Parkinson's symptoms. So right here at the top, they start talking about the features of Parkinson's. They use the acronym TRAP to represent tremor, rigidity, akinesia, and postural instability. They also say that there are other symptoms like flexed posture, freezing, and obviously like all the stuff they talked about in the abstract as well. So we know quite a lot about the clinical features just from the first few paragraphs here. So how are these quantified? How are these measured? Because they're all very qualitative. Well, the thing is there isn't really a single reliable way to measure them. And because of their qualitative nature, it is a little bit hard to track the progression and measure the severity of PD at any one point in time. But there are some rating scales they mention here. I don't know if I'm pronouncing this right, so correct me if I'm wrong, but Hohen and Yar. And this is a scale going from stage 0 to stage 5. It's not used very often though, I've never come across it. The more well-known one is the Unified Parkinson's Disease Rating Scale, or UPDRS. And this one goes from a scale of 0 to 4 and assesses, yes, they say assessing disability and impairment. And again, it is quite qualitative, so it's a little bit hard to measure, but it does work pretty well, and it's the most reliable way, at least right now. So in this particular study, they prospectively followed up with 297 patients with clinically diagnosed PD for at least 3 years. And they found that the annual rate of decline in the total UPDRS scores was 1.34 when assessed during on and 1.58 points when assessed during off. Okay, so just a little context there. What on and off means is it actually refers to the effectiveness of the medication. When levodopa is working and when it is actually controlling the symptoms, that is called an on period because it allows the patient a little more mobility, a little bit more freedom with what they can do. And when levodopa isn't working as well, when the effects kind of wear off, that is the off period. So that's what we know so far. Patients who are older and had the PIGD form of PD, if you don't remember what that is, just go up here. They just define it right there. Oh, sorry. They define it right there. Postural instability, gait difficulty. So patients who were older and had that form of PD at onset experienced more rapid disease progression than those who were younger at onset and had the tremor-dominant form of PD. So there's actually two forms of PD right now. They explain that pretty well over here, but basically there's normal form of PD, which is typically found in patients 65 years and older. And then there's early onset, which I believe is like 40 or younger. And that is a primarily tremor dominant form of PD, as they say. Furthermore, using the UPDRS scores, they found that the older group experienced more progression in mentation, freezing, and parts 1 and 2 of UPDRS subscores. But handwriting did not significantly deteriorate. But younger patients, on the other hand, were at higher risk for levodopa-induced dyskinesias than older patients. So what this basically shows us is that there are pretty significant differences between different forms of PD, and the actual clinical features might vary quite a bit, depending on if it's like regular PD, like the PIGD form, or whether it's the early onset form. And that is something you have to look for as well. This article is probably primarily going to focus on the PIGD form though, considering that they didn't really specify early onset, and early onset is also a lot more rare. So like when people say Parkinson's, they're usually referring to like the 65 plus, not early onset. And then they also mentioned that the current UPDRS scale is undergoing revisions, so they'll be able to detect small changes and integrate non-motor elements. Yeah, again, that goes back to the fact that the scale is very subjective, it is very qualitative, so there still needs to be a lot of progress, there still can be a lot of progress in how these symptoms are measured and how they are quantified. So yeah, that's like the gist of this section. And the next section is on bradykinesia. So we've heard about bradykinesia before in this article, but we don't know that much about it yet. All we know really is that it's a symptom of PD. But what does it do? What are its effects? So as this paragraph tells us, it refers to the slowness of movement and is the most characteristic clinical feature of PD. Basically, it manifests as slowness or slow reaction times, but it doesn't actually mean that PD patients lack the ability to make quicker movements or larger movements. It just means that they need an external pressure or something to stimulate that movement. As shown here, bradykinesia is also dependent on the emotional state of the patient, but this is true for a lot of Parkinson's symptoms. As I said here, for example, immobile patients who become excited may be able to make quick movements. This phenomenon suggests that patients with PD have intact motor programs, but have difficulties accessing them without an external trigger, such as loud noise, marching music, or a visual cue, requiring them to step over an obstacle. So it requires some sort of stimulation, but it doesn't mean that Parkinson's patients aren't able to make these movements. So bradykinesia is characterized by these particular symptoms that we've seen, like slowness of movement, typically because it just requires more of an electrical impulse, more electrical impulses rather, to kind of overcome a big enough threshold to make that movement, as shown here in the last sentence. Because patients with PD have decreased electromyographic activity, essentially just electrical activity in muscles, they need a series of multiple agonist bursts to accomplish larger movements. So all that's saying is that you need multiple action potentials and multiple bursts in order to make the same movement that perhaps someone without PD wouldn't need that many bursts. So you can go more into detail on this article. Again, I'll link the article in the description below. We're just going to do a quick overview of it though. We do actually have a couple of tables here. As you can see over here, we have a few tables we want to go over. And as I've said before, if you have tables, if you have diagrams, if you have pictures, always look at those because they're super useful. And it really does help to really internalize the information, and it's a bit easier to take in rather than just like walls of text. So we just kind of quickly went over bradykinesia. Let's go over tremors real quick too, and then we'll review these two tables. So what are tremors then? This is probably a little more intuitive. There are different types of tremors though, so we should go over that. Rest tremor is the most common and easily recognized symptom of PD. Tremors are unilateral, occur at a frequency between 4 and 6 Hz, and almost always are prominent in the distal part of an extremity, such as like, say, a hand or a foot. They are primarily supination-pronation tremors in the hands, but they can involve other places, they say, like the lips, chin, jaw, and legs. But they differ from essential tremors. Essential tremors are very similar to Parkinsonian tremors, rest tremors, but they aren't the same. Essential tremors happen more in the head, the neck region, maybe in the voice. So if you see these things, it's probably not a symptom or a sign of PD. Characteristically, rest tremor disappears with action and during sleep. Some patients also report an internal shaking that is not associated with the visible tremor. The tremor of PD is differentiated from that of essential tremor by a number of features. And then they say that they are referencing table 2 here, so we'll take a look at that shortly. They also say that there's another type of tremor called postural tremor that looks very, very similar to essential tremor, actually the same as essential tremors. But it's not quite the same. As they say here, essential tremors are a risk factor for PD, but postural tremors, for many years or decades before the onset of Parkinsonian tremor or other PD-related features, postural tremors might show up even before, and may also be somewhat of a risk factor. And then they say, in addition to rest tremor, many patients with PD also have postural tremor that is more prominent and disabling than rest tremor. Wait, sorry, did I misinterpret that then? No, I think that's fine. Okay, so they say, in addition to rest tremor, many patients with PD also have postural tremor that is more prominent and disabling than rest tremor and may be the first manifestation of the disease. Right, so as I was saying before, even before you are typically diagnosed with PD, you may experience these other symptoms, and these might be early warning signs. That's what they're basically saying in that paragraph. And there are several clues to the diagnosis of existent essential tremor when it coexists with PD, including a long-standing history of action tremor, family history of tremor, head and voice tremor, and then they go on to list a bunch of other symptoms. And this could possibly be when essential tremors and PD are found together. But again, remember that these are two distinct concepts, so we can actually go to table 2 now, where they actually show that there are differences between these two, between Parkinson's and essential tremors, such as age of onset, family history. Whoa, age of onset for essential tremors, like a huge range there. Family history, tremor frequency, tremor characteristics. So they basically list a ton of differences between the features. And while we're at it, we can check out this table as well. In this, they more broadly talk about different PD symptoms. They categorize it by motor symptoms and non-motor symptoms. And all of these are very, very important in characterizing PD, though it's really, remember here, TRAP, which they provided as an acronym before, those are the ones that will pretty much always be seen in PD. Everything else here, all of these non-motor symptoms and motor symptoms, are things that may be observed, but are not necessarily there in every single patient. Cool. So we know from table 1 that there are all these symptoms, and we've gone over a couple of the more prominent ones, such as bradykinesia and tremors. There's 2 more, remember, in that acronym. Rigidity is the R, and postural deformities, which is the P. So let's go over that next. So another symptom of Parkinson is rigidity. And as they say here, rigidity is characterized by increased resistance. Basically, a sort of stiffness, which prevents the normal range of movement that you would expect with the same ease of movement. And as they say here, it may limit like flexion, extension, or rotation about a hip joint. Rigidity may be associated with pain is another important point they make. Usually you'll find the gist of a section in like the first few lines or the first few lines of each paragraph. So they say here, for example, rigidity might be associated with pain, and then they give the evidence for that through a painful shoulder manifestation, which is one of the more common versions. And they also describe a study with 6,038 people and show that increased stiffness, tremor, and imbalance were possibly associated with a higher risk of Parkinson's. So essentially more rigidity meant a higher rate of developing Parkinson's and is perhaps even an early symptom. The thing is, rigidity also leads to other problems, which we'll get to later. It can also relate to other symptoms of Parkinson's. So the next section they talk about here is postural deformities. And here, again, as I was saying, rigidity can cause other problems as well. They do say here, in addition, rigidity of the neck and trunk, axial rigidity, may occur, resulting in abnormal axial postures. So basically, someone might be bent over due to rigidity causing postural deformities. Or maybe even with their hand, it might be bent at the joints in a slightly abnormal way. Or there might be unnatural stiffness, even in like facial muscles. And that's something you will notice very often with Parkinson's patients. Did they include any diagrams here? Yeah, okay. Yeah, I thought they did. So they do have some pictures here showing some of the postural deformities we were just discussing. For example, here in A and B, they show striatal hand and foot deformity in a case of Parkinson's. As I was saying, there's that slightly bent posture with the hand and with the foot as well. Like normally this type of bending is not normal. And imagine if your toes were always bent that way, then that might also cause some instability. And it might be harder to, like stand up and walk properly just because of the angle of the toe. You also do see something very similar in A, B, and C here. As we were talking about, like with the flexion and extension of the back of the back over here, you see this patient is bent over, but this flexion of the trunk that you see here is normal. Is like the normal position for this patient, even though it feels very abnormal looking at it, very unnatural position to stand in, but it actually takes the patient pushing himself into an extension posture to straighten the spine. On the other hand, when you see him laying down in the supine position, in C over here, his back is now straight, showing that these posture deformities they do have to do with very specific postures. They aren't just deformities in general. It has nothing to do with like the shape of the spine itself. It's just with the rigidity of the muscles in that position. So what are some effects of this rigidity and therefore of the postural deformities? Well, because of that, as I said before with the example of the foot in diagram B, it can cause postural instability. And you see, as they say here, postural instability is due to loss of postural reflexes and is generally a manifestation of the late stages of PD, and usually occurs after the onset of other clinical features. So it is one of the later stage symptoms that comes on, but it does have very impactful effects as you see later on. For example, as they say here, where was it? Yeah, the fear of falling can impair balance control in PD patients because there is an increased chance of falling with Parkinson's, again due to, say, like the angle of the toes or even just the rigidity. Like, imagine if anyone was pushed over, then you would normally like bend maybe a little to try to regain balance, and this might not happen in a Parkinson's patient. It's like a blade of grass versus like a tree trunk. A tree trunk isn't going to bend with the wind. So it's kind of like that. So there is an increased chance of falling, and that could lead to injuries. Where do they say? Yeah, postural instability, along with freezing of gait, is the most common cause of falls and contributes significantly to the risk of hip fractures. So as you can see, there are some pretty large effects of rigidity, postural deformities, and therefore postural instability in PD. And these are some of the main symptoms that show up in pretty much all cases of Parkinson's, and they aren't really like specific to individuals. Some symptoms that we will see later, though, like freezing, and they categorize like other motor abnormalities here and non-motor features. A lot of those are going to be more subjective and specific to the patient rather than just being like something that is found in all Parkinson's patients. So we can take a look at those sections next. Another symptom is freezing, though this is, unlike the previous ones, is not something that occurs in all PD patients, and like as seen with the TRAP acronym before, if any of those 4 symptoms are missing, then the diagnosis is probably not PD. But with freezing, that's not the case. You can have Parkinson's and not have freezing episodes. And actually, there are certain instances in which freezing episodes would be less likely for a certain patient. But in general, it does present a fairly large problem to many patients, as seen here. 47% of patients in a 12,000 based on 6,620 responses, 47% of patients reported freezing. So it still does constitute a symptom in a large number of patients. As seen in this paragraph here, it most commonly affects the legs, but can also affect arms and eyelids. So in this section, basically just describing what freezing is and where it occurs. That's like the gist of this paragraph. And then they describe how it occurs. They say that it might include hesitation when beginning to walk, which is start hesitation, or a sudden inability to move the feet during specific situations, like turning or walking through a narrow passage, crossing busy streets, approaching a destination, or other situations. There are many types of freezing as well, like start hesitation, turn hesitation, which was described before, hesitation in tight quarters, also mentioned before, destination hesitation, and open space hesitation, and are generally more common in the off state. However, medication does help with it, as shown in the area. Many patients also, as shown here, find ways to avoid freezing, such as walking to music or marching, showing that there are in fact ways to avoid freezing episodes. So, how come freezing might happen in some patients and not others? Well, there are some risk factors for it, like rigidity, bradykinesia, postural instability, and others. But, for example, if someone has tremor at disease onset, such as is more common with early onset, then freezing is less of a risk and probably won't happen. It also tends to happen more in the later stages. So, again, like people with early onset or people in like the early stages of PD or during the on periods. Not during on periods, but early in diagnosis, it is usually less common. But as they say here, freezing, particularly when it occurs during the on period, does not usually respond to dopaminergic therapy, but patients treated with sertraline have been found to be at lower risk. So there are some ways to kind of avoid freezing episodes, but generally I don't think most medications can really avoid it because most are targeted towards improving dopamine production and dopamine access in the brain. There are, however, other motor abnormalities as well, which we'll go through in 1, 2, 3, in the next 4 paragraphs. So let's just go to the first one real quick and take a minute to read through that. Feel free to pause the video, and then we'll go through it together. So what they're essentially saying in this paragraph is that with PD patients, there were actually some primitive reflexes that came back. And things like the glabellar reflex and the palmomental reflex were found in Parkinson's patients in higher rates than in other populations. Personally, that's not something I'd ever heard of before, and I don't know, I just found that really cool. And it's not particularly harmful either, so just a fun fact there, I guess. And in the second paragraph here, they go on to describe another type of motor abnormality, so go ahead and read through that. So what they're saying here is that many speech and swallowing disorders might also occur because of Parkinson's, and this is actually fairly common. Things like tip of the tongue phenomenon, not being able to remember what you're going to say, but having an idea of what you want to say, just not being able to find the right words. And also just in general with speech, not being able to properly say the words because of rigidity of the tongue is also quite common. And in general, these are due to orofacial laryngeal bradykinesia and rigidity. Okay, So that's the gist of the second paragraph here. So let's go on to the third. So take a few seconds to read through that, and then we'll begin. Okay. So what they're saying here is that there are also ophthalmological abnormalities, basically abnormalities with the eyes, such as altered tear film, visual hallucinations, decreased convergence. And there was nothing physically wrong with the eyes in any of these scenarios. It's just that the way things were perceived or the way the brain interpreted certain things, like with visual hallucinations in this case. And what they found, additionally, was that dopaminergic therapy generally improves these changes, but one study found no difference in smooth ocular pursuit between on and off periods. So there wasn't really much of a change between when medicine was working and when it was not. But that was only for ocular pursuit, and in general, dopaminergic therapy does help. They also have a little bit over here, which they say they list some more abnormalities, such as apraxia of eyelid opening, limitation of upward gaze, oculogyric crises, and there are others as well. These are just a couple. And okay, that's pretty much it for that paragraph, so go ahead and read through the last one, and then we'll go through that together. So what they're saying in this paragraph is that there are also respiratory different disturbances. So with breathing obstruction or restriction, and these can actually lead to death. For example, pneumonia, they say, is an independent predictor of mortality in nursing home patients with PD, and this may be related to rigidity, cervical arthrosis, or restricted range of motion in the neck, and the restrictive pattern may be related to chest wall rigidity. So essentially, the muscles in the chest wall itself begin to tighten up, begin to become more rigid. And over time, it's basically like your lungs stop expanding and contracting the way they're supposed to, leading to respiratory disturbances. So now let's see some of the non-motor features and symptoms of Parkinson's. As they list here, there are several different categories that these fall under, like autonomic dysfunction, cognitive and neurobehavioral abnormalities, sleep disorders, and sensory abnormalities, to name a few. So starting at autonomic dysfunction, this is typically not associated with PD. It's more associated with other Parkinsonian diseases like MSA, but it can be found in PD as well. And essentially, the autonomic system is just, it comprises of the body functions and the nervous pathways that you don't necessarily voluntarily control, like sweating, as they say here, sweating dysfunction, sphincter dysfunction, erectile dysfunction, hypotension. So all of these things you don't voluntarily control, but your brain does still control those processes. And with autonomic dysfunction, there might be problems with how your brain controls these processes. There are also problems with cognitive and neurobehavioral abnormalities. And as they show here, the Sydney Multicenter study of PD found that 84% of patients evaluated showed cognitive decline, and that 48% met the diagnostic criteria for dementia after 15 years of follow-up. So that is another quite common symptom of PD, dementia. And as they say here, it happened to 48% of these patients in the study after 15 years. So that shows that there is significant cognitive decline due to Parkinson's over quite a long period of time. And as they say here, patients with PD are at almost six-fold increased risk for dementia. So yeah, that's quite the increase. And that happens in number of patients. And they do say that this dementia also can come with other neuropsychiatric comorbidities, other neurological conditions basically, like depression, apathy, anxiety, and hallucinations. And like to a large degree this makes sense if you think about it. PD is caused by the death of dopaminergic neurons. So if your brain is producing less dopamine, which is basically a pleasure hormone, or at least that's one of its purposes, then it makes sense that you're going to be at increased risk for things like depression and anxiety. And honestly, this makes things even worse because already, like PD happens mainly among elderly patients, and senior citizens are already at a heightened risk for depression and other mental illnesses. So yeah, with those factors combined, it does explain the fact that 27.6% out of 114 PD patients screened positive for depression during the average of 14.6 months of follow-up. And these were only some of the observed symptoms. There were also others like impulsive behavior, like cravings, binge eating, compulsive foraging, and many, many others that they list. Basically all of this stuff. And they do say that these behavioral symptoms, sometimes referred to as hedonistic homeostatic dysregulation, have been attributed to a dopamine dysregulation syndrome associated with the use of dopaminergic drugs. Like levodopa, for example, is a dopaminergic drug. So these are agonists, which means they increase dopamine production in the brain, but over a very short period of time. So it causes like these kind of spikes and valleys in the behavior and in mood, which can lead to some of these obsessive compulsive and impulsive behaviors. There are also, as they say here, some sleep disorders related to PD. And now it has recently been recognized that these are actually features of the disease itself rather than features of the medication. For example, this is supported by REM sleep, or rapid eye movement sleep behavior, which occurs in 1/3 of patients. And this has been shown to act as a risk factor for Parkinson's. So it's not just that sleep disturbances can be a result of Parkinson's, but also that these can be potentially violent. As they say here, there might be yelling, swearing, grabbing, punching, kicking, or other like violent and maybe injurious motor activities, and this can come along with insomnia. And all these things together, like insomnia, sleep fragmentation, violent behavior, can really interplay and affect each other. So these are some possible sleep disorders that come with Parkinson's. There are also sensory abnormalities, as they say in this paragraph. Again, at any point, feel free to pause the video and just read the section yourself before we go over it. That might be helpful, just also to like practice how to read these, and then confirm it with what we go over together after. So they do say in this section, sensory symptoms such as olfactory dysfunction, pain, paresthesia, akathisia, oral pain, genital pain are frequent but are often not recognized as Parkinsonian symptoms. So these might be early markers for PD and may increase the risk though. But they are more attributed to, see it says here, it has been postulated that olfactory dysfunction is related to either neuronal loss in the corticomedial amygdala or to decreased dopaminergic neurons in the olfactory bulb. So it is possible that they do have a connection to PD, and they have been shown to increase the risk of PD, but it's not often that they're really recognized as Parkinson's symptoms. Mainly it's, as we talked about, sleep disorders, cognitive and neurobehavioral abnormalities, and autonomic dysfunction. Actually, less autonomic dysfunction, more the other two, but these are very, very closely tied to Parkinson's. So, considering all these symptoms, how is it that Parkinson's is diagnosed? Because from what we know so far, it seems like a lot of different patients could exhibit very different symptoms. So, there needs to be some kind of process to figure out if someone does have Parkinson's or if they just have something that looks like Parkinson's. And there are ways to figure this out, as shown by box 1 over here. This is UK's clinical criteria for diagnosing Parkinson's. First, they establish the presence of bradykinesia, and one of these symptoms like rigidity, rest tremors, or postural instability. Then they exclude other causes, and finally they have to find at least 3 of these highlighted criteria in order to actually confirm that it is Parkinson's. And even despite all of this, a lot of the times Parkinson's is actually misdiagnosed. Something like 30% of the time, Parkinson's disease is misdiagnosed as some other disease. And this can hinder treatment, for example, and is often only confirmed as misdiagnosis after autopsy. So it's still quite not really reliable. There is also, as shown in box 2, diagnostic criteria for Parkinson's, and this thing shows Group A, which are characteristics of Parkinson's, Group B features, which are suggestive of other diagnoses, so if there is anything from Group B, then it means it's probably not Parkinson's. And these criteria for definite PD, probable PD, and possible PD use these Group A and Group B features. Now let's go to the text, since we've taken a look at the diagrams, at the tables, which will probably help us here. So, what are the diagnostic criteria here? So, PD is diagnosed on clinical criteria, and there is no definite test. And as I previously mentioned, they say that pathological confirmation of the hallmark Lewy bodies. Lewy bodies are the protein complexes that are usually found characteristic of Parkinson's. They are found on autopsy and have been considered the criterion standard for diagnosis. Obviously, you can't do that on a live patient though, so it's a little bit harder to find. In clinical practice, diagnosis is typically based on the presence of a combination of cardinal motor features, associated and exclusionary symptoms, and response to levodopa. So it's based on these 3 criteria. Although the diagnosis of PD is straightforward when patients have a classical presentation, differentiating PD from other forms of Parkinsonism can be challenging early in the course of the disease, when signs and symptoms overlap with other syndromes. And like I mentioned before, there are a variety of other syndromes which do have Parkinsonism-like features, like progressive supranuclear palsy, multiple system atrophy, and several others. So as we saw in box 1 and 2, there are some diagnostic criteria, but as they acknowledge here, the reliability and validity of these criteria have not been clearly established. For example, here, a study that included 100 patients who underwent biopsy after clinical diagnosis using the UK system found that 76% of patients met the pathological criteria. When the diagnostic criteria were retrospectively applied, accuracy improved to 82%. In a later study of the brains of patients examined by neurologists, diagnostic accuracy was considered higher. So it keeps getting higher when more criteria is added, but it's still not 100% reliable. As shown here, misdiagnosis of PD can happen for a number of reasons. such as misdiagnoses due to someone mistaking essential tremor for Parkinson's, or maybe Alzheimer's disease, or vascular Parkinsonism, which are all very similar symptom-wise. But one thing that was found to improve the diagnosis and the accuracy of the diagnosis was this. A study evaluating 800 patients from the DataTop trial suggested that movement disorder specialists are skillful at diagnosing PD. So, PD, when diagnosed by movement disorder specialists, was more accurately diagnosed, and as shown here, based on autopsy data imaging studies, response to levodopa and atypical clinical features, only 8.1% of patients did not meet the diagnostic criteria at the final diagnosis. So there was an improvement in accuracy seen here. So other than these more qualitative means, are there any other ways of really measuring and classifying PD to set it apart from other similar diseases? Well, there are some, but they aren't typically used. As seen here in the differential diagnosis category, Parkinson's disorders are classified as four main types: primary, secondary, heterodegenerative, and multiple system degeneration. And tremor, early gait abnormality, postural instability, and many others can be used to differentiate PD from other similar disorders. So there are some other ways to actually differentiate these. As shown here, levodopa efficacy was one of these ways. Levodopa tends to be more effective for Parkinson's patients and not really so for non-PD diseases. So that might be one way to actually differentiate, but again, it's not entirely accurate because even for many patients with pathologically proven PD, only 77% of patients actually responded well to levodopa, if they had any response at all. So because of that, you can't say that everyone who does respond well to levodopa has PD and everybody who does not respond to it does not, because there is really only 77% of patients who responded to it. As I say here, subcutaneous injections of apomorphine were also used to differentiate between PD and other similar disorders, but it doesn't really contribute much to diagnostic evaluation and is not superior to levodopa therapy. There are also neuroimaging techniques, but although these are quite effective, to actually bring out their full potential, there needs to be more refinement in resolution and improvement in sensitivity. And only then can their full diagnostic potential be realized. Until then, we have to stick with our qualitative systems, unfortunately, relying on really noticing the clinical symptoms in order to diagnose the disease. There is one more section here, a quick conclusion. Considering we went through the entire article together, it shouldn't be too hard to really understand the conclusion at this point. So I'll give you a minute to read that and see how much you can understand from it by yourself. Okay, so I hope you learned a lot from this video. If you have any questions or any clarifications you would like me to include, please just let me know in the comments. As always, please give me a like and subscribe if you liked this video series, and hope to see you next time.